First we shall start with introduction of Necator Americanus. We proceed with some explanations of symptoms of a hookworm infection. Then this presentation will explain on how to diagnose and test an infection, treatment of the disease, preventive plans of hookworm infections among community, some nursing interventions in order to prevent the infection spread and its rationale. Finally, list of references. Human hookworm disease is a common helminth infection that is predominantly caused by the nematode parasites Necator americanus and Ancylostoma duodenal. Organisms that play a lesser role include Ancylostoma colonicum, Ancylostoma brasiliensis, and Ancylostoma caninum. Hookworm infection is acquired through skin exposure to larvae in soil contaminated by human feces. Soil becomes infectious about 9 days after contamination and remains so for weeks, depending on conditions. Worldwide, hookworms infect an estimated 440 million people. Although most of those affected are asymptomatic, approximately 10% experience anemia. Hookworms may persist for many years in the host and impair the physical and intellectual development of children and the economic development of communities. Historically, hookworm infection has disproportionately affected the poorest among the least developed nations, largely as a consequence of inadequate access to clean water, sanitation, and health education. The frequent absence of symptoms notwithstanding, hookworm disease substantially contributes to the incidence of anemia and malnutrition in developing nations. It occurs most commonly in the rural tropical and subtropical areas of Asia, Sub-Saharan Africa, and Latin America. Almost 2/3 of migrant workers screened in a study are found to be infected with intestinal parasites, including one alien species not detected here before. This finding shows that a mass drug administration needs to be carried out on newly arrived foreign workers, says the group of researchers at University Malaysia who carried out the study. According to its principal investigator, some parasitologist Associate Professor Dr. Norimah Zink, the study, which was done on 388 migrant workers within a year of their arrival from September 2014 to August 2015 in the Klang Valley, found that 62.9% of them were positive for at least one parasite species. They were found to have roundworms, hookworms, whipworms and tapeworms. One of the workers even had all 4 parasite species. The workers participating in the cross-sectional study of intestinal parasitic infections among migrant workers in Malaysia came from 5 sectors: manufacturing, construction, plantation, domestic and food services. They were mostly recruited from Indonesia, Nepal, Bangladesh, India and Myanmar. The total of 4 nematode roundworm species, Ascaris lumbricoides, Trichoceres trichiurae, Enterobus vermicularis and Ancylostoma duodenal, 1 Cestohymenolapis nana and 3 protozoan species and amoeba Histolytica dispar, Giardia sp. and Cryptosporidium spp. were identified in the workers. High prevalence of infections with A. lumbricoides 43.3% was recorded, followed by hookworms 13.1%, E. histolytica 11.6%, Giardia 10.8%, T. trichuro 9.5%, Cryptosporidium 3.1%, H. nana 1.8% and E. vermicularis 0.5%. Those infected with A. lumbricoides may be asymptomatic or suffer from bloating and stomach ache, and if serious enough, the worms will be defecated. The hookworm life cycle divided into 5 phases. The first phase is when the hookworm larvae enter the human body through the skin via hand and foot or mouth and pass into the bloodstream. The second phase is the larvae travel through the bloodstream to the lungs. The third phase, secretions from the human lungs, which contain the larvae, are coughed up and swallowed, passing into the stomach. The fourth phase is when the larvae pass into the human intestine, where they mature into adult worms. The head of the adult hookworm has sharp, curved, dental plates that enable them to cling to the intestine. Finally, eggs produced by female hookworms leave the human body in the stool. The eggs hatch into larvae in the soil. People infected with human hookworm larvae occasionally have a less obvious itchy rash for a few days around the area of skin where the larvae penetrated. Respiratory symptoms such as a cough and wheeziness may develop when the larvae reach the lungs a few weeks after exposure. Severe infections may cause fever, abdominal pain, diarrhea, loss of appetite, weight loss, fatigue, anemia. Blood loss leading to iron deficiency, anemia, and protein loss are the most serious symptoms. Hookworm infections can be diagnosed by inspecting a stool sample under a microscope in a laboratory and looking for the eggs. If there is an infection, the number of eggs will be counted to see how severe it is. Apart from that, tests that can help diagnose the infection include complete blood count (CBC) with differential. This infection may also affect the results of a D-xylose absorption test. The goals of treatment are to 1. Cure the infection. 2. Treat complications of anemia. 3. Improve nutrition of the patient. Infection can be treated with various methods, either from nutritional diet or medication. Parasite-killing medications such as albendazole, mebendazole, or iron telpamote are usually prescribed by doctors. You'll need to take the medication for 1 to 3 days. The medications are usually effective and have few side effects. Ivermectin, used for other worm infections, does not work for hookworm infections. However, albendazole or another medication called ivermectin can be used to treat the cutaneous larva migrans infection of the skin. Symptoms and complications of anemia are treated as they arise. The doctor will likely recommend increasing the amount of protein in your diet. If you have anemia, you may need iron supplements. Folic acid may also be recommended to help replenish your red blood cells. The best way to avoid infection is not to walk barefoot in areas where the Necator Americanus is common and where there may be human fecal contamination of the soil. Also avoid other skin contact, especially by bare hand with such soil, and avoid swallow the soil. Infection can also be prevented by not defecating at outdoor and recreational areas. The important prevention method is through health education, where community involvement through health education is an important aspect in the control of infection. Health education should be aimed at promoting the use of sanitary latrines, prevention of soil pollution, and good personal hygiene practices such as wearing of protective footwear and making use of health facilities. Community also need to avoid sewage area and other areas with high risk of infection, since the incidence of infections reflect the quality of life of the people and its cultural habits. Its reduction is directly dependent on improvement of economic and social conditions. Wash hands and teach patient and standard practice to wash hands before contact with patients and between procedures with the patient. Instances when to wash hands: before putting on gloves and after taking them off, before and after touching the patient, before handling an invasive device, Foley catheter, IV catheter, regardless of whether or not gloves are used, after contact with body fluids or excretions, mucous membranes, non-intact skin, or wound dressings. If moving from contaminated body site to another site during the care of the same individual, after contact with inanimate surfaces and objects in the immediate vicinity of the patient, after removing sterile or non-sterile gloves, before handling medications or preparing food. Prevention number 2 is to encourage intake of protein-rich and calorie-rich foods to support the immune system. Prevention number 3 is to encourage fluid intake of 2,000 to 3,000 milliliters of water per day, unless contraindicated. Fluids promote eluted urine and frequent emptying of bladder, reducing the stasis of urine. In turn, reduces risk for bladder infection or urinary tract infection. Prevention number 4 is to encourage coughing and deep breathing exercises. Frequent position changes helps reduce stasis of secretions in the lungs and the bronchial tree. When stasis occurs, pathogens can cause upper respiratory tract infections and pneumonia. Prevention number 5 is to recommend the use of soft bristled toothbrushes and stool softeners to protect mucous membranes. These may compromise the integrity of the mucous membranes and provide a port of entry for pathogens. Prevention number 6 is to provide surgical mask to visitors who are coughing and provide an explanation why the mask is important to wear. Educating visitors on the importance of preventing droplet transmission from themselves to others can help reduce the risk of infection. Please instruct visitor or patient to cover mouth and nose during coughing or sneezing. Use tissues to contain respiratory secretions with an immediate disposal to a no-touch receptacle. Wash hands with soap and water afterward. Final prevention is to limit visitors. By restricting visitation, it reduces the transmission of pathogens. Important information that we may need to be aware. Hookworm infections can occur in pets, especially puppies and kittens. If your pet has an infection, you can get it indirectly. You won't get it from petting your dog or cat. The eggs are passed in your pet's stool and hatch into larvae. The eggs and larvae are found in the dirt where your pet leaves stool. You can get a hookworm infection by touching contaminated dirt with your bare hands or feet. You can also get it by accidentally eating contaminated soil. To reduce your risk, make sure your pets are vaccinated and dewormed by your veterinarian. Also, avoid walking barefoot in areas where pets leave feces. This is especially important when you might come in contact with animal feces from pets whose health conditions are unknown, such as at a park. It is estimated that a third of all pregnant women in developing countries are infected with hookworm. 56% of all pregnant women in developing countries suffer from anemia. 20% of all maternal deaths are either directly or indirectly related to anemia. Numbers like this have led to an increased interest in the topic of hookworm-related anemia during pregnancy. With the understanding that chronic hookworm infection can often lead to anemia, many people are now questioning if the treatment of hookworm could affect change in severe anemia rates and thus also on maternal and child health as well. Most evidence suggests that the contribution of hookworm to maternal anemia merits that all women of childbearing age living in endemic areas be subject to periodic and helmintic treatment. The World Health Organization even recommends that infected pregnant women be treated after their first trimester. Regardless of these suggestions, only Madagascar, Nepal and Sri Lanka have added deworming to their antenatal care programs. This lack of deworming of pregnant women is explained by the fact that most individuals still fear that an helmintic treatment will result in adverse birth outcomes. But a 2006 study by UiTM found that when comparing the group of pregnant women treated with mebendazole with a controlled placebo group, both illustrated rather similar rates in adverse birth outcomes. The treated group demonstrated 5.6% adverse birth outcomes, while the control group had 6.25% adverse birth outcomes. Furthermore, Larock illustrated that treatment for hookworm infection actually led to positive health results in the infant. This study concluded that treatment with mebendazole plus iron supplements during antenatal care significantly reduced the proportion of very low birth weight infants when compared to a placebo control group. Studies so far have validated recommendations to treat infected pregnant women for hookworm infection during pregnancy. The review of effects of anti-helminthic anti-worm drugs given in pregnancy found that there was not enough evidence to support treating pregnant women in their second or third trimesters. The women who were treated in the second trimester and the women who had no treatment showed no difference in numbers of maternal anemia, low birth weight, preterm birth or deaths of babies. The intensity of hookworm infection as well as the species of hookworm have yet to be studied as they relate to hookworm-related anemia during pregnancy. Additionally, more research must be done in different regions of the world to see if trends noted in completed studies persist. Co-infection with hookworm and Plasmodium falciparum is common in Africa. Although exact numbers are unknown, preliminary analyses estimate that as many as a quarter of African school children, 17.8 to 32.1 million children aged 5 to 14 years, may be coincidentally at risk of hookworm. While original hypotheses stated that co-infection with multiple parasites would impair the host's immune response to a single parasite and increase susceptibility to clinical disease, studies have yielded contrasting results. For example, one study in Senegal showed that the risk of clinical malaria infection was increased in helminth-infected children in comparison to helminth-free children, while other studies have failed to reproduce such results. Among laboratory mouse experiments, the effect of helminths on malaria is variable. Some hypotheses and studies suggest that helminth infections may protect against cerebral malaria due to the possible modulation of pro-inflammatory and anti-inflammatory cytokines responses. Furthermore, the mechanisms underlying this supposed increased susceptibility to disease are unknown. For example, helminth infections cause potent and highly polarized immune response characterized. However, the effect of such responses on the human immune response is unknown. Additionally, both malaria and helminth infection can cause anemia, but the effect of co-infection and possible enhancement of anemia is poorly understood. While annual or semi-annual mass and helminth administration is a critical aspect of any public health intervention, many have begun to realize how unsustainable it is due to aspects such as poverty, high rates of reinfection, and diminished efficacy of drugs with repeated use. Current research, therefore, has focused on the development of a vaccine that could be integrated into existing control programs. The goal of vaccine development is not necessarily to create a vaccine with sterilizing immunity or complete protection against immunity. A vaccine that reduces the likelihood of vaccinated individuals developing severe infections and thus reduced blood and nutrient levels could still have a significant impact on the high burden of disease throughout the world. Current research focuses on targeting two stages in the development of the worm, the larval stage and the adult stage. Research on larval antigens has focused on proteins that are members of the pathogenesis-related protein superfamily, ancylostoma-secreted proteins. Although they were first described in Phenoclostoma, these proteins have also been successfully isolated from the secreted product of N. Americanus. N. Americanus is currently the leading larval stage hookworm vaccine candidate. The randomized, double-blind, placebo-controlled study has already been performed. 36 healthy adults without a history of hookworm infection were given 3 intramuscular injections of 3 different concentrations of NASP2 and observed for 6 months after the final vaccination. The vaccine induced significant anti-NASP2 IgG and cellular immune responses. In addition, it was safe and produced no debilitating side effects. The vaccine is now in a phase 1 trial. Healthy adult volunteers with documented evidence of previous infection in Brazil are being given the same dose concentration on the same schedule used in the initial study. If this study is successful, the next step would be to conduct a phase 2 trial to assess the rate and intensity of hookworm infection among vaccinated persons. Because the NASP2 vaccine only targets the larval stage, it is critical that all subjects enrolled in the study be treated with anti-helminthic drugs to eliminate adult worms prior to vaccination. Adult hookworm antigens have also been identified as potential candidates for vaccines. When adult worms attach to the intestinal mucosa of the human host, erythrocytes are ruptured in the worm's digestive tract, which causes the release of free hemoglobin, which is subsequently degraded by a proteolytic cascade. Several of these proteins that are responsible for this proteolytic cascade are also essential for the worm's nutrition and survival. Therefore, a vaccine that could induce antibodies for these antigens could interfere with the hookworm's digestive pathway and impair the worm's survival. 3 proteins have been identified: the aspartic protease hemaggluteinase APRIL1, the cysteine protease hemaggluteinase CP2, and a glutathione S transferase. Vaccination with APRIL1 and CP2 led to reduced host blood loss and fecal egg counts in dogs. With APRIL1, vaccination even led to reduced worm burden. Research is currently stymied at the development of at least one of these antigens as a recombinant protein for testing in clinical trials. Moderate hookworm infections have been demonstrated to have beneficial effects on hosts suffering from diseases linked to overactive immune systems. This is possibly explained by the hygiene hypothesis. Research at the University of Nottingham conducted in Ethiopia observed a small subset of people with hookworm infections were half as likely to experience asthma or hay fever. Potential benefits have also been hypothesized in cases of multiple sclerosis, Crohn's disease and diabetes. Some research conducted has shown favorable results using hookworms to treat celiac disease. Though research points to anti-allergenic properties associated with hookworm infections, the FDA does not currently recognize hookworms as a treatment.